And so just saying out loud that they love pediatrics, they think this is great, is very likely to actually shift their underlying attitudes and ultimately their behavior, which is really interesting that you could arrive at a decision with those stakes simply by saying something multiple times out loud.
Welcome back to another episode of the podcast for doctors by doctors. I'm Dr. Michael Jerkins, joined by the one and the only Dr. Nedwin Palmer III. Dr. Palmer?
It's actually the 3.5. We kind of landed in the middle there. We're trying for some non-integer generations.
Are you really the third, though?
No, it's also not Nedwin. We've known each other for more than 10 years. At a certain point, you'd think you'd understand anything about my name. What country am I from? Let's see if we've got that much.
Oh, you were descendants from the King of the North.
Yeah, well, I'm very much a White Walker. I'm a nice creature. Yeah.
Oh, isn't his name Nedwin Stark?
Hey, no, Nedard.
I need to go back and read those again.
It was a classic. I would have bet you would have read it.
I did. I read all of them. I forgot.
And, reading comprehension is supposed to be higher than watched comprehension. And yet here we are.
It was years ago. Years. Anyway, but actually what's interesting about that is thinking about, because the last time I read a book from the series was in medical school. And luckily today, I was going to say, is I don't remember what that was like learning and making decisions in medical school. And that seems to be what our topic is today by the nationally renowned, I would say, thought leader in medical education, the one and only Dr. Josh Daly, who's going to enlighten us about, I think, trends that are really important on how doctors make decisions on what kind of doctor they're going to be, what specialty do they choose, what's good and bad about our current medical education system that potentially allows trainees to maybe not make the best choice. So I'm excited to get to talk to him. He's always very thoughtful.
I'm thrilled to talk to Dr. Daly. It really, so much of what he wrote in this article, and obviously Dr. Daly's other work, has resonated with me, both personally and professionally. Let me ask you a quick question as we lead into this. Specifically, we're going to be talking about how medical students make decisions for residency and for the specialty choice that they're going to make. How far into medical school were you when you knew that med-peds was a thing?
Probably a month before I applied.
Same. Yeah. So,
yeah.
What were you going to be other than a med-peds physician?
I for a year or two thought general surgery.
Okay.
And I did general surgery research, if you could call it that.
Wow.
And went to the ACS conference, and I was the only one not in a sports coat. And that's when I knew that maybe this wasn't for me.
Hey, we're going to talk about cultural fit today with Dr. Daly and how important that is.
Then family medicine.
Okay.
And then landed on med-peds.
Those all make sense because they're all super generalist roles.
Mm-hmm.
I don't think if you had said you want to be, let's say, a retina surgeon or some specialist of ophthalmology and then went to med-peds, I'd be more surprised. Those are all super generalist roles. I get it. You want to operate on the whole patient all the time. I get it. There's consistency there.
Yeah. I had friends in medical school that wanted to be family medicine physicians. And then once they got their step one scores back, all of a sudden wanted to be dermatologists. So, who knows? Maybe they changed their mind after they got exposed to dermatologist after step one, but maybe not. Maybe something else. Who knows?
Maybe this all has to do with the bias of decision making that med students make off an insignificant amount of information to make a decision that affects the rest of their careers as physicians.
That's a really good segue into our wonderful guest today. Let's just get right to it. The interview with Dr. Josh Daly. All right, Dr. Josh Daly is here with us. He is a practicing pediatric cardiologist at Arkansas Children's Hospital and the University of Arkansas for Medical Sciences, where he serves as the program director for the Pediatric Cardiology Fellowship Program. He also co-directs a medical student course, Personal and Professional Financial Essentials for Physicians, which equips fourth-year med students with the essential knowledge and skills to manage their financial futures. He and his wife, Lauren, are parents to 4 children, Will, Caleb, Abby, and Ellie, ranging in age from 13 to 3. Dr. Daly, welcome back to the podcast.
Thanks for having me. It's great to be here. I thoroughly enjoyed the last time that I was on the podcast, and then value both your friendships and enjoy getting to catch up with both of you.
Awesome. Well, Dr. Daly, for listeners who have not read the awesome paper yet, which is in Medical Science Educator, titled The Influence of Cognitive and Emotional Biases in Medical Specialty Selection, Path to Burnout, is pretty awesome. But let me ask you, what got you even thinking about this topic at all?
Well, a number of years ago, actually, toward the end of residency, I recognized that I devoted a significant portion of my life to learning about medicine and that I was not growing in other areas. And so I think a mentor had mentioned just the value of reading broadly. So I decided I was going to develop a discipline of reading a book a month. And so I've done that ever since. And I read a number of books, and I read all the initial kind of books that were on my list. And then I started taking, based on recommendations that others made, I put those on the queue. And I came across the book Predictably Irrational by Dan Ariely, who's a psychologist, that really was my first exposure to this space. This idea that we are predictably irrational, that we deviate from rationality in very clear and obvious ways, and that's independent of our intelligence, of how well trained we are in a domain. In fact, there's even literature that suggests that those that are more intelligent and have higher training in their area are even more prone to these underlying cognitive biases. And I like to think of myself as very intelligent and rational, and I saw these same biases manifest in my own life. And so, in part, out of a desire to make good decisions, and then also just because it was really fascinating, I kind of did a deep dive into that. And so I read other books, and then within the last few years, I've done a lot of writing in this space, and I've tried to read everything that's out there and become an expert on the science of high-quality decision-making and the way cognitive biases get in the way and keep us from making good decisions.
And I think for most of the listeners, they may be aware, but in case those listeners are not aware, all the doctors you guys see, the physicians, the specialists, all at one point had to figure out what kind of doctor they wanted to be. First of all, they had to get into medical school. And then once they were in medical school, they were taking the classes. And sometime before they graduated, in fact, several years before they graduated, had to figure out what they wanted to try and apply for to be able to interview for a residency program, and then later fellowship for specialties. So there's a lot of big decisions made pretty quickly, only a year, maybe two into their medical training career. What are some of the patterns that you saw in trainees early on that maybe clued you in people are potentially making an irrational decision when deciding what to be?
Well, let me step back briefly and provide a little more just granularity to some of what you alluded to, in case some of our readers aren't as familiar. So for those that enter medical school, their first 2 years are primarily classroom-based. You learn things like physiology and anatomy and have very little exposure to actual clinical medicine and taking care of patients. And then during your third year of medical school, suddenly you're thrust into clinical rotations. You're on pediatrics and internal medicine and surgery and so forth. And you basically have 1 year to make a decision about what you want to do the rest of your life. And there's a lot of pressure you feel in that time frame, not only to make a good decision, but to be a competitive candidate, to make sure that you pick something that you can match into, and then to optimize your application in such a way to increase the chances that you match into that. And there's this pressure not only to make a decision, to make it very early in the year. So many people within those first 6 months feel the need to decide what they want to do and then start going down that path. And then, unlike so many other areas of our economy, in medicine, once you pick a specialty, in most cases, there's not a lot of going back. You can't just reinvent yourself 3 or 4 times in your career and change specialty. If I wanted to become an orthopedic surgeon today, that would require me quitting my job, applying for residency, going back, making significantly less than I do now, and entirely retraining to be an orthopedic surgeon. Such that, 1, my wife would kill me if I even suggested the idea of us doing that. And 2, that the costs associated with that basically keep us from making that decision. So there's this brief point in time in which we have these limited experiences and we have to make these very high stakes decisions that determine the pathway we're on for the remainder of our career, without a lot of opportunity to change from that. And I've seen a lot of medical students make some pretty significant, what I view as mistakes. And as I have explored this material more, and especially the psychology underpinning it, boy, did I see a lot of those manifest early on for me. So it's easy for me to point out the mistakes in others, but I feel like I should share just some of how I made that decision and some of the really obvious mistakes now looking back that I made. So I was the first doctor in my family and had didn't have a lot of exposure to medicine. We had a few family friends who had a parent that were a physician, and I had a vague sense of that. And really, most of my exposure to medicine was with orthopedic surgeons. I was an athlete in high school, had some injuries, spent a number of time with about orthopedic surgeons. And I remember thinking, these guys are pretty cool. They look a lot like me. They're a lot of times former athletes, seem like pretty cool guys. And even in retrospect, while it's a little hard to admit this, they were Caucasian males who looked like me in that respect as well. And so it's easy for me to view them and think, oh, I'm similar to them. This would be a good fit. So I entered medicine, and when people asked me early in medical school what I'm going to do, I'd say, I'm not sure, probably orthopedic surgery. That sounds pretty cool. And I persisted along that path for a while, even though I really had no deep understanding at all of what it actually meant to practice orthopedic surgery. I hadn't been in the OR. I didn't know if I had the aptitude or technical skill to be a good surgeon. I didn't know if I even liked surgery. I just knew these seemed like cool guys, and I kind of looked like them. So that was one of my first big mistakes that I made along the way. Then I entered, as I transitioned into second year of med school, a lot of first year med school was memorization. And that didn't come as naturally to me. My background is in physics. I really like math and thinking through things from a logical perspective. And for the first time when we learned cardiovascular physiology, it suddenly was not memorizing data or facts, but understanding systems and equations. And so it came a lot more naturally to me. So I decided I wanted to be an adult cardiologist. And I felt the need. We're very uncomfortable with uncertainty. I certainly was then. And so it felt great to say out loud that I knew what I wanted to do. And I even probably overemphasized how how confident I was in an attempt to minimize the cognitive dissonance I was probably experiencing in the background. So I told people with certainty. I knew what I wanted to do. This is what I'm going to be great at. So I entered my third year of medical school with that intention in mind. I then rotated to the VA right off the bat. And my overall experience, while there's a lot of great things that are done at the VA, was not extremely positive for a variety of reasons, from the system and the kind of pathology that you see. But in the midst of that, I spent some time on cardiology. And I recognized that the things that I loved about cardiovascular physiology didn't actually play out on a day-to-day basis in actually practicing cardiology.
What year was this of school?
This was my third year of med school. And I had made up my mind. I told everybody I was going to be an adult cardiologist. I knew what I wanted to do. I was that kid in the class that was completely certain that this is what I was going to do. But I realized that really, one, most of what you do is kind of algorithmic. If this, then this. There's not a lot of thinking about the actual physiology. Two, most of it's coronary artery disease or heart failure. And most of it's geriatrics. And you're caring for someone that often contributed to their own disease, which they need to be cared for. But there's something different about caring for a child in terms of my ability to be empathetic and really the opportunity for impact when they didn't bring their disease upon themselves. So I had a little bit of a struggle on VA. I didn't enjoy it that much. And I kind of wrestled with what am I going to do? Then I rotated on pediatric cardiology. And I had this experience where I recognized very early on that the things I loved about physiology were what pediatric cardiologists did on a day-to-day basis. So once again, I was very uncomfortable with uncertainty, so I just made up my mind that day. This is what I'm going to do, and told everyone that I was definitely going to do that. And I went down the pediatrics route, matched into residency, and then I still remember my intern year very vividly. As is the case for a lot of interns, there's this period in the middle of the winter where usually your overall affect is down. You haven't seen this. You get to the hospital before the sun comes up, and you leave after the sun goes down, and you're dealing with a lot of illness, and you're in the inpatient setting. And so I was experiencing all those things. And I rotated on inpatient pediatric cardiology. And I knew this is what I was going to do. And I really wanted to press my attendings. And so I showed up early, and I did all the reading and really wanted to be on point. But at the end of the day, I felt worn out. I did not feel excited. I didn't feel energized in any way. And I didn't really enjoy that month. And I was an intern on inpatient pediatric cardiology. And this was a few years before you guys were at Cincinnati Children's. So we were still doing paper charting then, which is kind of crazy. And so really when I didn't recognize how much of my time was spent doing this, but I basically went around and collected lots of data and wrote it down and did a whole bunch of charting and put in a lot of orders. So that's the bulk of what I spent my time doing. And then I wasn't actually practicing much cardiology. But at the end of that month, I didn't want to say I changed my mind, but I was really wrestling with that. Then I spent time in emergency medicine. That was my next month. And at the end of every shift, I was energized. I was excited. I enjoyed what I was doing. And I really wrestled with, man, am I meant to be an emergency medicine doc? Maybe I've had it wrong all along. This is what I enjoy work so much more when I'm in the emergency medicine area than when I was on pediatric cardiology. And I'm really grateful that I finally recognized this. At the end of that month, I was thinking about shifting gears, which is really uncomfortable for me. And I was really trying to figure out ways I could rationalize not changing. And all of a sudden it dawned on me. What I loved about emergency medicine, I really liked getting to actually talk to patients. I liked being the one to go in and taking all the data and figure out what was going on, actually developing an assessment. And I liked developing my own plan. Basically, I liked functioning like a doctor. That's what I loved. It wasn't the actual practice of emergency medicine at all. And what did I dislike about my rotation in pediatric cardiology? It was having to collect tons of data every morning, do paper charting, do all the scut work. That's what I disliked. What I was actually practicing as an intern had nothing to do with the actual true practice of pediatric cardiology. And so if I had just followed my gut and my emotion in that moment, I think I would have made a really poor decision. Now, could I have had a great career as an emergency medicine doc? Yes, I think I could have. But I think I'm a much better fit for pediatric cardiology. And I'm so grateful with the help of a little bit of mentorship and some reflection that I realized that's what I liked. And so I was able to double down, have some additional experiences in pediatric cardiology where I actually saw what it was like to read echoes, be in the cath lab, and do the things pediatric cardiologists do. And I realized it was a much, much better fit. So I really almost went off, made what I think would have been a mistake at that point. And that's really what's called an attribution error. It's a combination of an attribution error and the affect heuristic. The affect heuristic is when you use your emotional state as a surrogate for whether you should pursue something or withdraw from something. So in other words, if you feel happy, that's what you should do. If you feel disappointed or sad, then you should withdraw from that. And you assume that that emotional response is a reliable indicator of whether that would be a good fit for you. And then with an attribution error, what I did in that case is I misattributed my emotional state to the inherent practice of that specialty, when really it had nothing to do with it whatsoever. And so it was a combination of those two that almost got me all the way off the path that ended up resulting in me being a pediatric cardiologist, which I'm so grateful for. But those are some of the classic examples that I just, looking back at where I made poor decisions, or I almost made poor decisions. And I see that all the time in medical students, say those same kinds of things. Another very common one that I see is the manifestation of basically confirmation bias. When someone makes a decision, especially if their identity is interwoven in that. So maybe I decide I'm meant to be a neurosurgeon. Maybe I had some experience with a neurosurgeon early in my life and I knew this is what I meant to do. I'm going to interpret all of my experiences and all of this data in such a way that causes me to confirm what I already believe about myself, especially when it relates to a core aspect of my identity. So you may get all the way through medical school and have very little aptitude to be an actually good neurosurgeon, but you've been able to interpret all this data in a way that reinforces the idea that that's what you should do. So when people draw a conclusion earlier, they have to be really careful about getting the outside view and not just reinforcing what they already believe about themselves. That's one of the other classic ones that I see played out all the time with medical students.
I had a couple of quick thoughts, Ned, before your question. One is, I guess you mentioned this in one of your biases, but every time I get an email from Ned, I feel like bad. So I shouldn't trust that. And I should actually step back and say, no, this is okay. I shouldn't trust my emotional state when I receive this email from Ned Wynn. And that's just kind of lighthearted. But the other thing was, it is kind of funny how, like, at least when I was having students rotate with me on medicine or peds, more often than not, when the students came in and stuff came up of what she wanted to do, they all wanted to be an internist or a pediatrician, even though, like, you could probably say, you're probably just telling me that. Obviously, I'm giving you a grade. There's some weird incentive structures there. But, like, I wonder if that psychologically, just hearing themselves say that over and over, what they want to be, also causes some noise in their decision making because of just how they're graded, quite frankly, on these rotations.
Yeah, I definitely think so. And One, they, as you mentioned, in an attempt to subtly impress you, they're going to indicate that they're very interested in what you do and they think your work is meaningful and interesting and so forth. And then, but our desire to minimize cognitive dissonance kicks in. And so we do everything we can to avoid pain. And loss aversion in particular basically says that we place twice as much emphasis on avoiding pain as we do pursuing equivalent gains. And one of the most painful things is when we experience this dissonance, when we believe ourselves, we have a way that we view ourselves, and there's data that mismatches with that. And when you say out loud that you believe something or that you are interested in something or like something, you're very likely to actually change your underlying attitudes and your subsequent behaviors in a way to align with what you said to be true. Because no one wants to be the kind of person that says one thing and does something else. That's really uncomfortable, especially when you're confronted with that own behavior in yourself. So we do everything we can to minimize that. And so just saying out loud that they love pediatrics, they think this is great, is very likely to actually shift their underlying attitudes and ultimately their behavior, which is really interesting that you could arrive at a decision with those stakes simply by saying something multiple times out loud.
Smile till you're happy.
Yeah, I wonder if you could actually do this on looking at the sequence of the core rotations for third and fourth year and see if that was predictive on what people selected.
First look bias, kind of like basically our first exposure bias, I suppose.
And to what he's saying of just you get these reps of what you've told people out loud what you want to be for 8 weeks or 12 weeks, whatever it is.
Yeah, that's called anchoring bias. When you anchor on your first exposure. So if surgery is the first thing you do, you anchor to that, and then status quo bias kicks in, and you tend to maintain that unless there's a compelling reason to deviate from that. So I'm not aware of any research that's been done in that area, but I think it'd be very interesting to try to tease that out. There's a lot of research that's similar that's been done outside of medicine that clearly has application here, and I'm sure that influences.
Absolutely. So what I want to talk with you about, the structure that you laid out that I went through, it sounds like we all went through of, really 2 years in the classroom, 2 years clinical, very structured. There are some schools that are starting to blow that up in terms of early clinical exposures, getting you into typically outpatient clinic because, a little lower stakes, a little lower velocity at an earlier stage. Have you seen or experienced any of these kind of like curricular shifts and how the students maybe still anecdotally are responding to those in their specialty choice with more confidence?
We have made some of those changes here at the university I'm at, but we have not probably made as significant a shift as occurred in some other places that are more on the extremes of pushing those changes into earlier in medical school. Of course, everyone says it's good because often the people talking about it, the people came up with that idea and implementing it. And so once again, of course, they're going to say it's great and makes a difference.
There's some bias there too about it being your idea bias. Yeah.
Oh, you got it. And then everyone went into medicine, or the vast majority of us, in part because we like caring for patients in clinical medicine. So of course, medical students are going to say it's a good idea, but someone simply saying they like it has very little to do with whether it actually brings about the change that you desire. If the change that you're going for is to improve the quality of the decisions that we make, then someone simply saying they like that change is a completely separate construct. And so I'm not aware of anybody actually investigating that. What you'd have to start with is how we actually assess the quality of decisions that are made currently. And we don't have a gold standard for that. We don't, we can look at things like, did you match into your residency or did you go unmatched? And that may indicate that maybe you had overconfidence bias and were shooting for something that you should not have shot for. We can look at burnout and whether you experience burnout or not, although most doctors experience burnout at some point in their career. That doesn't necessarily mean they made a bad decision. You could look at board passage rate. You could look at professional fulfillment, especially down the road. You could look at how successful you're in a career using different domains. There are ways you could try to get at it, but as it currently stands, we don't have a great way of assessing whether we're actually making good decisions regarding our specialty selection and the impact that has down the road. So it's hard to really determine whether these changes are bringing about the desired result when we don't have a great way of measuring it currently, unfortunately.
Yeah, quality has always been one of the trickiest things to measure in clinical medicine across the board, right? Even just from as simple as care delivery. It's been absolutely a struggle to measure something that's that multifactorial, which can have kind of like these outsized impacts from confounders that completely like obviate your ability to really tease it apart. You mentioned burnout in there, and I wanted to talk about that because your very strong lead in was about how we make decisions and the biases that we can introduce to our own decision making. But I'd love for you to connect that to the burnout, right? Burnout, again, this big hydra of a multi-headed beast that affects physicians. More than half of physicians get it at some point in their career. Like, how do we connect the early decision making biases that play into the specialty choices we make to future burnout? And like, how strong is that connection or correlation?
Well, one, there is an absence of any robust data that indicates a clear connection. I wish we had that data. So there's a lot of connections that make intuitive sense. And I think there are some conclusions that are suggested based on research outside of medicine. But there's very little data that allows us to draw any definitive conclusions within medicine itself. Additionally, when you think about burnout, the tendency, and that's obviously a hot topic for a lot of reasons, it's very important. But the tendency when you think about physician wellness is to view a physician as either burned out or not. And I think there's a better way of thinking about it. It's a little bit more holistic. And that's this idea. So if you imagine, let's say we have a Likert scale from 1 to 10, 10 being a peak in terms of wellness for a physician, and 1 being the absolute worst. Let's say a 1 and 2 and a 3 are in the burned out range, and then a 4 and above are not. So the tendency is, how do we get docs out of this 1 to 2 and get them to a 4 or a 5? Oh, they're not burned out. That's great. But there's this other end of the spectrum that's also really important but isn't talked about as much, and there's not as much research surrounding this, what some people call professional fulfillment. So this idea, are you deeply engaged in what you do? Do you feel connected with those that you're working with? Is your work meaningful? Do you get excited about going to work each day, et cetera? And that's a smaller subset of doctors. And so when you actually, if you categorize physicians, there are basically 3 categories you could be in. You could be burned out and not professionally fulfilled, which is a big chunk, which is anywhere from 25 to 50% of doctors, depending on the specialty when you look at it. Then on the other end of the spectrum, there's the smaller subset that are professionally fulfilled, but not burned out. And depending on the study you look at there, that may be 30%, 20%, 25% in that range. And then there's this big gap in the middle. And they're not burned out, but they're also not professionally fulfilled. They're not depressed. They're sleeping okay at night, but they're not that engaged at work. They're kind of punching their clock. They care for patients, but they're not that excited about it. They're earning a paycheck. And there's this big gap in the middle. And so as you think about the match between your specialty selection and how that fits with your underlying aptitudes, where you develop knowledge and skill, what your interests are and your values, and the match of all of those, there's this tendency to focus just on the burnout end. But I think while it certainly impacts that, I think it impacts the full spectrum. And it may have a greater impact on the other end of really, if there's a great match, your ability to be deeply engaged in your work and really enjoy what you do, I think is probably really accelerated. So, but once again, this hasn't been studied in any really rigorous way within medicine. So we're really taking research from outside of medicine and applying it here. But I think that's where potentially the greater link is. Now, when you look at burnout, one of the primary drivers of burnout is lack of autonomy. And there are multiple contributors, but that's one of the big ones. And I think if you pick a specialty in which you have underlying aptitudes that allow you to become great at it, then you get excellent training so you have fantastic knowledge and skill in that area. And then you're also deeply connected with those you're with, and your work is meaningful, and all those kind of pieces come together. You're going to have a lot of autonomy, either in terms of what you do. A lot of the lack of autonomy can stem from we may not feel equipped to care for what's in front of us that day. Also, the more competent we are in that domain, the more we can leverage our knowledge and skills to get a job that gives us more control both over a job and the rest of our life. And autonomy is interesting. It's not just autonomy at work. It's not just like I control what my day looks like at work. But in so much as your work gives you autonomy over the rest of your life, that really reduces your burnout. So if I'm working 60 hours a week and I've got kids at home and I'm barely getting home and throwing them in bed, and I'm up late and taking care of things around the house, and I'm constantly feel like I'm juggling too many things in the air, I feel out of control at work and at home, that's a recipe for burnout. And so your appropriate matching between your specialty and your underlying aptitudes and knowledge and skill, I think increases the likelihood that you can leverage for a job and choose a job that gives you autonomy at work and allows you to get autonomy outside of work. So then you can, for instance, you can get paid more. If you're really good at what you do, you can negotiate for more money. Money can buy you time if you're intentional about it. Now, if you go out and buy just new, better, nice things, that's not going to make you happier. But if you use that in such a way that you then can buy back time and buy time affluence, then you can get a more autonomy outside of work. And so there's this complex interplay between a lot of variables, but I do think a big piece of that is making a good decision on the front end. Now, it's not the end all be all. Let's say that there's someone listening to this that looks back at how they selected their career, their specialty, and recognizes a number of biases that may have manifest. They're not destined for a bad job or for burnout. There are a lot of things you can do in your present day job to reduce your odds of burnout, to increase your experience of professional fulfillment, to optimize autonomy in your life, and so forth. So it's not an end all be all. It's not like there's one decision and then you're destined, but it is a very important decision that has huge impact through the rest of your career.
So where you ended there was going to be my next question, and it's really difficult, and I appreciate your description of it's very difficult to tie the specialty decision making to burnout directly and to correlate that. But I think what we do have a good sense of and understanding of, and maybe I cheated by reading your article, is like we do see biases in decision making. And so do we at least have a rank order of some of the most common biases that you've seen in residency decision making or specialty decision making that med students are making today? It all starts with recognition. So maybe this just helps our listeners to kind of call or see themselves in some of these biases. Like, I think you identified, Josh, Michael and I identified in the preamble that we definitely made some of these. So what kind of like, if you had to pick a top three that you see are some of the most pervasive and problematic when med students are picking specialties?
Probably the most significant is what many people call the mother of all biases, and that's confirmation bias, which we've talked about a little bit already. But this tendency to interpret events and data in a way that confirms what we already believe, especially when that relates to our identity. I think that's the most powerful and the one we have to be most careful with. And in addition, there's actually a flip side of that I'll just briefly mention. We often are greatly influenced by the advice we're given from our mentors. And our mentors tend to give us advice that aligns with the decisions that they made. So, in large part to minimize their own cognitive bias, their own cognitive dissonance, this discomfort that they feel. So probably all three of us who train at Cincinnati Children's are going to have a very favorable view of Cincinnati Children's. And we talk to a medical student who's thinking about doing pediatrics, say, oh yeah, you should really consider Cincinnati. You're going to get great training there. And we're going to give advice that aligns with what we did, because we like to think of ourselves as great doctors. And so it'd be very uncomfortable for us to conclude, I'm kind of average, or a little below average. My training wasn't that great. So we're likely to give advice that aligns with what we've already done. So the same is, so when you're getting advice from a mentor, they're probably going to recommend a path that looks kind of similar to what they did. And that's in large part due to this desire to minimize cognitive dissonance, and then your mentor engaging in confirmation bias. So it works on both sides, which is really interesting how that plays out. But that's number one, confirmation bias. The second is this combination of affect heuristic and misattribution errors that I talked about. This tendency to rely on our emotional state and our gut. And I'll do a little bit deeper dive into that. There's a lot of confusion, especially in the American psyche and culture, about the role of emotion in our life. There's this belief, especially in Disney movies, that your genuine self is entirely a function of your emotional state in that moment, and that you should just follow your heart, and your heart is equated with emotion, and that's who you genuinely are. And anyone that's ever been a parent knows when a kid does that, it causes all sorts of problems in the house. The last thing you do, that's a marker of immaturity. You just do whatever you feel like you want to do in that moment. So, but we tend to believe that emotion should be our guide. And then in the midst of a really complex decision, we feel uncomfortable. So then we grab on to follow your gut. And some mentor may have told us that as well. So we tend to really rely on emotions. The reverse is also true, though. I think it's really unhealthy to ignore emotions. Emotions are a big part of who we are. And when you experience happiness or sadness or disappointment, it's really important to investigate what were the drivers behind that. What was the context in which I experienced it? Why did I experience that? Was it there was other stuff going on outside of my life that had nothing to do with that rotation? Is, in some cases, a secondary emotion. Anger is typically a secondary emotion. Often if I have a strong elicited feeling of anger, there's actually an underlying emotion of embarrassment or hurt or something else that's going on. So when you have a strong emotion, you should neither let it guide you, nor should you ignore it entirely. But you should be curious and investigate why that's there, what that's revealing about you, about your beliefs, your attitudes, about your insecurities, what you're holding on to, and explore some of that. So, but we get that wrong a lot on this affect heuristic of just letting that guide you. And when that's combined with the misattribution error, when we have a strong positive feeling and we attribute it to whether this specialty would be a good fit for me when it had nothing to do with that, then that really leads us to making bad decisions. And the research that's out there on specialty selection pretty consistently shows that the most powerful determinant is mentorship. Basically, did you have a good mentor in that specialty who you wanted to emulate and took an interest in you? If that happened, there's a very good chance you're going to pursue that. And so on a given rotation, you may have an upper level resident or an attending who's really kind and is a great teacher and is engaged with you, and then even says, hey, you could be really good at this. And that feels so great. And we might think, man, this is what I meant to do. Or we may have an upper level resident who's a jerk, who puts you down, who says unkind things, who makes you do scut work, and you think, I hate this. Surgery's not for me, or whatever it may be. And that had nothing to do with the practice of surgery. It had everything to do with you don't like working with jerks. And it just happened to be that you had an upper level resident that was acting like a jerk that day. So we have to be really careful about this misattribution error, especially when combined with our emotional states. So those are the two biggest. And then the third that I think we have to be very careful of is the representative heuristic. And that's this idea that I look like them, so that's a reliable indicator that I'd be a good fit in that area. And that can take lots of forms, whether it's gender, race, interest, age, where you're from, that kind of thing. There's lots of stuff that can get played out in that. We have to be really careful. In many cases, looking like that person has nothing to do whatsoever with practicing in that area. So those would be my three big ones. If you look at the article, I provide a lot of additional biases that there's often this complex milieu, and there's not a single bias, but multiple come together to lead us to make bad decisions. But those are the biggest by my estimation.
Those are the biggest. Yeah. And so two things, you mentioned the look-alike bias. And what I didn't get to say is, was baldness a factor in you thinking about orthopedic surgery? Just in terms of the shaved head bald? Yeah.
So interestingly, I was not bald then. I had hair when I made that decision.
Okay. Oh, wow. Okay.
Only if it hadn't been for that, then maybe I would have been an orthopedic surgeon.
That's right.
Today, wearing an Under Armour polo with the look like you could have sold anybody on orthopedic surgery, Josh. Yeah.
Don't I look like it? You got it.
But look, you mentioned, I think, that transition there at the end, and you called out the potential for a toxic surgical rotation, maybe because you had one. I had one. I'll raise my hand. And so I know interest in it. And so when you wrote in the case study in your paper about Ellie, well named, of course, and about the toxic experiences she had in surgery, obviously for many of the reasons you identified, a poor lookalike fit, a poor mentorship fit, and in general, just a poor fit and a poor understanding of what the practice today was in terms of a career in general surgery. How often are you seeing that students mistake this toxic environment for a poor specialty fit?
Well, since I practice in pediatrics and we never have any toxic environment issues, that's not something I see a whole lot.
Never.
No, not at all. No. I do hear about it from other specialties at times, but no, I think that's a big impact on what medical students pick, especially with the emphasis on mental health and enjoying what you do. I think that's probably even been elevated in importance. And as you look at shifts in the kinds of specialties that newer doctors are choosing, there's been a shift a little more toward lifestyle specialties and away from some of the specialties that are more demanding and potentially historically more malignant. And so with that shift in emphasis, then combined with all these biases and the way that academic medicine works and the kind of experiences that medical students often have on these specialties and the roles of medical students. So often the role of medical student has nothing to do with the inherent practice of that specialty. We kind of have this belief that we make them do the grunt work and then they can work their way up. But if their exposure to the grunt work leaves a negative emotional experience, they may just dismiss your entire specialty because of that, even if it'd be a great fit for them. So I think that plays out in a number of ways, and in part is related to both the structure of rotations and then the individuals. And it's easy for me to, give surgeons a hard time, or some attending that was a jerk, but they have their own stories, and they have the stuff that they may have not slept the night before. They may have had a patient die. They may be going on dealing with stuff outside of the hospital. So that doesn't make them a jerk, but in that moment, they may be manifesting some of that more toxic behavior for a whole variety of reasons. But that has a huge impact on what we select.
Absolutely. And then the flip side of that, just to keep it going, Caleb, also well named in your case studies, about somebody who overly identified as the orthopedic surgeon, who we're now learning may have some personal connections here. Early over identification and almost that again, that confirmation bias and that anchoring bias, like you described, what could Caleb have done to change the outcome? Like, what exists in here to counteract those heuristics that once you recognize those biases within yourself?
Well, what's interesting, this is stepping back a little more broadly and looking at how we can protect ourselves from bias. And so there may be a belief that, hey, if we just teach people about biases, then people will recognize them themselves and protect them. And that does help a little bit, but not nearly as much as you might think.
It's the nutrition label approach, right? Put the information out there and then let people, seeing is modifying behavior.
You got it. So especially when you look at behavioral economics and public policy, the far more powerful variables are changing the systems and changing them in a way that makes the manifestation of these biases less likely and nudges people toward better decisions. And so if I could just wave a wand and do whatever I wanted to, it wouldn't be that every med student would know all this material. I think it's cool, and I think they should learn it. But we would change the way that we structure medical school in terms of the experiences, the coaching that's offered, and how these decisions are made. So ideally, early on, Caleb would have been paired with a mentor who recognized some of this, would have engaged in reflective processing about his experiences, what his beliefs were, how to interpret these experiences, to engage in some effective forecasting about what his life is likely to look like in the future, what will be important for him, and through that process to draw some of those conclusions earlier on about what would be a good fit or not. And then there's lots of other things in terms of early exposure, the kind of exposure to different specialties that I think would have been extremely helpful. That case in particular, multiple variables come together in a way that ultimately Caleb ends up in a state of burnout in which he really doesn't enjoy his job. A lot of that isn't just specialty choice. There's a lot of other stuff that go into that. But I would focus on the system side if I could do anything. But from the perspective of actually helping individual learners, when I can't change the whole system, having an understanding of how we make decisions and incorporating a few practices into their life can be helpful. So one of the things that I created a tool that is in the manuscript that a third-year medical student can use to help them assess. I just spent 8 weeks on surgery, and to walk through what emotions did I experience, what did I like, what did I not like, why did I like it, how strong of a candidate would I actually be, what are some other steps that I can take to get additional experiences that help me make a better decision. Those kinds of things I think could be very helpful at an individual level.
So let me ask, because you mentioned this, systems are more powerful than just providing information. So Dr. Daly is chancellor for a year, can take it down to the studs and rebuild it. What would you rebuild to limit the amount of bias that med students have to navigate to pick their most, I don't even know what adjective I would use, their specialty that they actually would enjoy and find joy with the most?
There are a number of things I would do, but one of the top things on the list is I would develop evidence-based aptitude testing for physicians. So we often select a specialty based on interest, not aptitude. So aptitude is an underlying, it's how quickly we can learn a given skill or task and our ability to absolutely excel at that. So there are some areas in which just through brute force you can develop knowledge and skill, but it may not come as naturally, it may be more difficult, and your top end expectation may be less. And there are other areas that are a great fit in which you can hit a much higher level. And the better your specialty fit is with your underlying aptitudes, I think overall the better choice that you will have made, and your opportunity to experience fulfillment at a high level is much greater. And so we often mistake interest. So maybe I like sports, so I think orthopedic surgery would be a great fit, when actually the aptitudes to be an orthopedic surgeon involve fine motor control, three-dimensional visualization, thinking in space, those kinds of skills. And if we could have actual testing that tells you what are the areas you score very high in, what are the areas you score low in, and then it can help match you to what specialties could be a good fit. Not that there's one magical specialty that's a perfect fit and nothing else would work well. But there are some that would be a better fit and some that would be less of a good fit. So it would start with that, and I'd want to do it very early in med school, before you start to form all these opinions and all these biases start to well up, pushing you down a path that's hard to deviate from. So it would start there, and then there'd be intentional clinical exposure from day one in a diversity of clinical settings. So you wouldn't have your only internal medicine rotation at the VA. You would potentially have some time in the academic hospital, maybe a private practice hospital, maybe outpatient clinic. And you'd have it built in so you get a more accurate sampling of what's actually available in that specialty. There's another bias called the availability heuristic, which is where we have this, there may be a limited amount of information we've had exposure to, but we assume we have the whole truth. So as an internist, Michael, you probably recognize the wide breadth of opportunities with internal medicine. That as a third-year medical student, I just thought you did inpatient medicine and or you did clinic, and you took care of chronic diseases, and that's it. That may have been my only limited experience, when there's actually a lot of other things that are involved in internal medicine. And then there's other areas of medicine, like I never rotated in radiation oncology. I'm not even sure I knew that was a specialty because I had no exposure to it whatsoever. So you have these limited experiences during your third year, and you think, oh, I know everything that's available in medicine. And in reality, there's a lot of specialties you don't get exposure to, and then a number of specialties where your exposure is very limited and don't actually represent the full breadth of experiences in that specialty. So to that end, I would intentionally design those clinical rotations in such a way to gain more breadth. You can't cover everything, but there's a lot of room for improvement on that end. And then I would train attendings in some basic coaching skills and some basic decision-making practices with some tools, and have them meet regularly with each medical student and process their experiences and help direct them toward what specialty would be a good fit or would not be. And it would ideally be driven by data. So if you have someone that may have done well on poorly from a grade perspective and USMLE perspective, even if they think dermatology is great, they're not going to match. And so you do them no help by encouraging them and trying to make them feel better about themselves. So there'd be a data-driven component that would help them make high-quality decisions that also increase the likelihood they're actually going to match in a given area. So you kind of bring all that together, but it would start from day one of med school, not be this 12-month period during third year where you start from not knowing anything to having a full experience of all the rotations and then make a decision at the end of that.
Makes sense. I was probably better that you didn't know about radiation oncology, just given your love of physics. You might have skewed that way, but that makes a lot of sense. I think it involves especially the teaching attendings part will probably honestly be the biggest uplift or biggest challenge probably. But I actually love that model. I had one additional question before we go to our true false section of the show. How do you recommend, because we've talked about the people who maybe look back and realize they were subject to some bias and maybe that affected their specialty choice, but what about the people who take step two and they did all this stuff, they recognized all of these potential bias, and they say, yes, I definitely know I want to be a urologist, and this is the path I'm going to take. And then to your point, they take step two, or there's some other objective data that says, you know what, you actually probably never going to be a urologist. How do you coach those medical students?
Well, first, I think you have to be willing to step into the discomfort of having an honest conversation. You do them no favors by saying, oh, it'll be okay. Oh, everyone has struggles with that test. You're still a great candidate. That will not help them. All that does is it discharges some of your discomfort you're experiencing at that moment. It's a very selfish approach to take. One we all tend to take, but it has more to do with you than it does with them. So you need to, I think, have an honest conversation with them. And then in almost every area, if you distill down the things about a specialty that are a good fit for you that you want, you can almost always find those in another specialty that you may be a good match for. So it's not like you go, oh, back to the drawing board, well, what am I going to do now? If, let's say it's a surgical specialty that you're planning on pursuing and you really like the actual procedural component. Well, there are other specialties that may be less competitive that would still give you a lot of the procedural component. Or you like the longitudinal relationship with patients, or you like the inpatient setting, or drill down on some of those aspects that you are drawn toward a good fit for you and find other specialties that offer those as well. In almost every case, there's something that you could match into that would still be a good fit, and I think you could have a good life.
I love it. That's great tidbits. I'm going to now move on to our, Dr. Daly, our true false section where I say a statement and you tell me if you believe it is true or false. So the first, true or false, the longer the review of systems is in a medical record, the more likely it is to be false.
That is a true statement.
Ned, do you agree with that? I agree with that.
Yeah, I don't think anybody would.
Anybody's actually written or filled out a review systems.
Some of that's just odds, like if you know how math works.
Yes.
If you ask 30 questions, then the odds one of those is incorrect is much greater than you ask 5 questions. So, I mean, some of it's just knowing how that works.
I love that.
Yeah. I would say it's further from reality. The more that is, the longer the pan positivity of the ROS, but it might be a little more my cynicism. So,
all right, next statement, true or false? Tuition to medical school will eventually start to decrease.
In real dollars, is that what you're asking?
In inflation-adjusted dollars.
I think that could go either way. I'm neutral on that. I think it'll probably remain constant in real dollars.
And not go up?
Not in inflation-adjusted dollars on a median. I think the average might, because outliers influence that. And as more people want to go to medicine, there'll be some of these outlier med schools that can charge an insane amount, which will bring up the average. But I think the median, the 50th percentile, will probably stay about the same in inflation-adjusted dollars. But I could be completely wrong. That's my kind of best estimate.
I love it.
It's optimistic.
Yeah, it's optimistic. Actually, but it would be optimistic, Ned, as if you said, I think it's going to be a lot cheaper. But I don't believe that to be likely true either.
It'd be unrealistic, though. So I mean,
that's right. Okay, next statement, true or false? The future of medicine is bright.
True.
Why do you say that?
Well, for a variety of reasons. One, I know that our underlying psychological tendency in these kind of assessments is to say that things are worse now than they were 10, 20, 30 years ago. And then we project that into the future. So the tendency is to fixate on the negatives and think they're getting worse. And so things are going to continue to get worse. But that really deviates from the actual data that when you actually look at, there's a book called Factfulness in which they basically, the author unpacks, like, is the world getting better or worse? And when you actually look at objective data across the board, the world's a lot better than it used to be. And every indicator suggests that's going to continue. And so we tend to fixate on our individual thing that we think is worse than it used to be and presume that that will continue. And so one is just because I know some of the data behind that and underlying psychological tendencies. In addition, I'm really excited about the ways that AI is likely going to improve the medical care that we provide and the ways in which doctors practice. And in particularly probably hopefully offload a lot of the tasks that have been very time consuming and unenjoyable for doctors.
What's interesting is that's actually my next statement. True or false, AI will ultimately result in making patients healthier.
There will be ways in which it does and ways in which it does not. And the net effect will be about even. I think the quality of the health care that's provided will be improved. The actual patient outcomes may not be, in large part because there will probably be behaviors that are encouraged by AI that are ultimately not in the best interest of the entire population that we care for.
Like what? What would AI encourage that would actually potentially harm patients' health?
I think AI will probably drive us to spend more time on devices and be more reliant on looking at screens. and they'll all have a net negative effect on the quality of the relationships that we have, which is the primary driver of human flourishing when you look at the research. So I worry about some of that downstream effect as we spend more time looking at screens and we spend more time interacting with computers, that it may take away from meaningful connection with actual people in your life. So that would be one way that I could see it having a deleterious effect.
True or false, wearable devices that measure things like heart rate variability and pulse ox improve patients' health?
I apologize.
All good.
I'm on a group text and like 20 people decided to text all at once. I think there are ways in which that benefits us and ways in which that hurts us. Tracking the amount of exercise you engage in a day is likely to increase the amount of exercise you do. But having more data in someone that's otherwise healthy actually just increases the false positive rate. So if you put a teenager, and they wear an Apple Watch, and the underlying prevalence of arrhythmias in that population is very low, and it indicates an arrhythmia, the odds as an actual arrhythmia are unbelievably low. And so I see a lot of patients in my clinic because people are worried about that, and I don't think that improves the overall care. So there are ways in which it helps and ways in which it hurts.
Okay, last true and false. Most doctors, if they could do it over again, would choose a different specialty.
I think that's false. And I think for a number of the reasons that we mentioned, it's really painful for me to say, hey, this really important decision I made that's crafted who I've been, I made the wrong decision. And we all like to think we're great doctors in our specialty. It's painful for me to say, I'm an okay cardiologist. I'm not that great. I don't want to draw that conclusion. So I am very drawn toward drawing the conclusion. I'm a great cardiologist and I made great decisions. And so I'm very likely to conclude that the specialty I picked is a good pick for me and I should not have made a different decision. Now, it's very different than whether I actually ended up in the optimal specialty or not. But I think most doctors would say they're glad they did. If there was something egregious that happened in their life, then they're likely to conclude the opposite. But it takes something pretty egregious for them to say, I made a bad decision. I wish I'd done something different.
Got it. All right. And here's our final question we ask every guest. Dr. Daly, I think we asked you this last time you were on, but what is one thing that you have recently changed your mind about?
This is fairly specific, but I've been doing some financial modeling, looking at physician compensation, and I had some prior beliefs that are simply not supported by the data. So for instance, it's easy for me as an academic doc to say, I've given up a higher compensation to pursue academia, to teach the next generation of cardiologists, teach medical students, and to think that I'm making some sacrifice to do this. And I just finished doing a pretty complex analysis looking at the lifetime earnings of pediatric cardiologists. And basically, academic pediatric cardiologists, we don't give up anything to do it. We make about the same in discounted dollars from a lifetime perspective as going into private practice. And so this belief I've had all along simply is not supported by the data, at least in my field. There's some other fields in which it is, but not in pediatric cardiology. So that's just one. That was just in the last couple of days that I realized that I've been wrong in some of the conclusions I've drawn around that.
But you get to believe you're a martyr, and that makes you feel better about doing the work that you do. So
You got it.
I wish you still had that blissful ignorance.
Well, Dr. Daly, thank you for shedding light on a lot of this. If people want to find out more about you and your work, where should they go to read more?
You're welcome to reach out to me individually. My contact information is on the Pediatric Cardiology Fellowship Program site for University of Arkansas for Medical Sciences. I also write for the White Coat Investor, and a lot of my articles are there if you look at the columnist section. And then I'm happy to answer any individual questions that folks may have through email. It's probably the easiest way.
Awesome. Well, Dr. Josh Daly, thank you for joining us and appreciate your time.
Yeah, enjoyed being here. Thanks for having me.
Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. The next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.